Can you see the screen?
Yes, madam, we can see this.
Okay, so I'm just going to start with give me a minute.
Recording in progress.
Right, okay. So we are going to start with the basic newborn care and then go on to resuscitation, right? So improvement in newborn care doesn't require advanced technology, right? But it needs some basic training. So the important thing is to give evidence-based care to a baby within the first hour of life. So we are going to talk about caring for the baby during delivery as well as handling the compromised baby. So if we talk about the first bit, so first we are going to talk about what happens at the delivery and how we care for the baby, right? So initially we have to prepare for the delivery, right, in order to ensure proper care. So preparation before delivery, those of who have done the neonatology bit would remember that we talked about how we prepare. So we have to minimize infection. So we need to do hand washing, wear double pairs of gloves, and make sure we have a sterile kit for cord clamping. Before we wash our hands, we need to make sure that the temperature around this area is suitable for the baby. So the baby is should not have cold air current. So we need to either switch off the AC or stay away from the AC, switch off the fan, close the windows, switch on the warm towels. So the towels we are going to keep on this resuscitator, right? So you have all seen a resuscitator. In the picture also you can see one. And yeah, help mom to wear clothes easy for skin to skin as well as breastfeeding. And before we wash our hands, it's important that we check whether the oxygen supply is working and the suction is working, and whether we have sort of closed the windows and done all this. So once we have done all that, we can wash our hands using the 5-step method and then wear the double pairs of gloves, after which only we should be checking the equipment. So this is just to remind you about the 5 steps of hand washing, right? Rubbing the palms together. I don't think I need to go into detail. Rubbing back of both hands, interlacing fingers, then rubbing the thumb and then the wrist. So once we finish hand washing, so we have done some things for temperature control, right? And we have washed our hands, and now you have to wear double gloves. We also should have sterile equipment for clamping the cord. So we need the plastic cord clamp as well as we need arteries to hold the cord and a scalpel or a cord, a scissor which can cut the cord. Right. So here you can see switching off the fan, switching off the AC, closing the window. What is the mechanism of heat loss here? Can one of you unmute and quickly tell? Yapa?
Evaporation, madam.
Sorry?
And evaporation and radiation.
Not really. These are air currents.
Convection.
Convection, right? These are convection air currents. Good. So this is by stopping the fan, window, closing the window, stopping the AC. We are preventing convection air currents by heating or switching on the warmer 30 minutes prior. So if you are not sure, better to switch it on. That minimizes conductive heat loss, right? So again, to remind ourselves, what is the procedure at delivery? We deliver the baby onto the abdomen, keep the baby on the mother's chest, start the stop clock, immediate and thorough drying, and delayed cord clamping. So we deliver the baby onto the mother's abdomen. Here you can see the baby is very wet, right? So on the mother's chest, we should have those 2 towels, and then we wipe the baby, make sure the wetness goes away. So here, by wiping the baby, what is the mechanism of heat loss we are overcoming? Vinu?
Evaporation.
Evaporation, right, good. So we are, by delivering the baby onto the abdomen, we ensure colonization of the baby with mother's bacteria, which are usually from the community, which is a good thing. Versus if we keep baby on the bed, baby gets colonized with pathogens, right? Either on the bed or resuscitate. So unnecessarily, we must not keep the baby either on the warmer or on the delivery bed. If the baby needs resuscitation, different matter, we'll have to keep the baby on the resuscitator. Then why do we deliver onto the chest? So we have talked about this during your IVOG as well. We want to minimize heat loss via conduction. In utero, baby is at 37, mom is at 37, whereas the delivery room bed is around 28, 32 or less. So by keeping on the delivery room bed or something, some other thing, or the resuscitator, what will happen is the baby's heat will travel from baby onto the delivery room bed. So therefore, it is better to keep on the mother's chest. Then also by delivering the baby onto the mother's chest, there is better establishment of breastfeeding. So immediate and thorough drying of the baby, right? As soon as the baby is born, we have to have the towels wherever we are keeping the baby. We are going to dry the baby. And that will prevent heat loss by evaporation. And we need to discard the wet towel and wrap the baby in the other dry towel. So we need at least 2 dry warm towels per delivery. And how do we warm it? And why should we use warm towels? Because if we touch the baby with a cold towel, there will be heat loss via conduction. Right. So then while we are drying, we have to assess the baby's condition. And the 4 things we are going to assess are color, tone, breathing, heart rate, CTBH. If the baby is born in good condition, in this picture you can see color is pink, tone is flexed, baby is breathing, or there's good cry, and heart rate is more than 100 per minute. If that is the situation, we don't need to remove the baby from the mother. We place the baby on the mother chest. So mother's bare chest touching on baby's chest. This is skin to skin care until the first breastfeed is over. So while the baby is there, we should label the baby. Then you can put the clothes, the baby shirt the other way around, covering the back where the chest is open. Then the socks and the hat, and then we can put mother's jacket and cover both baby and mother so they are both comfortable. When the baby demonstrates hunger cues, baby will feed. So why is skin to skin care important? Because it prevents heat loss via conduction. It helps colonization with maternal flora. It establishes breastfeeding, stabilizes heart rate as well as respiratory rate, increases bonding, and calms the baby down. So there are many advantages of skin to skin contact, which you should know. Right. So the other thing that can happen is baby may not be born in good condition, but baby may be born in poor condition, in which case the baby may be blue or pale. The tone is limp, poor breathing, or no breathing at all. And the heart rate is slow. Right. So in this situation, we have to start resuscitation. Okay. All right. So we will talk about resuscitation in a minute. Okay, so either way, we have to give cord care to the baby. We have to clamp the cord on either side using the 2 artery forceps, right? And then in the middle of that only, we will use a plastic cord clamp, right? So when we are using the plastic cord clamp, it should be about 1 inch away from the baby's umbilical from the stomach. So because we have to have enough space in case we need to insert an umbilical line. Just 1 minute, I'm getting a call from the hospital. Hello? Yeah. Okay, sorry about that. Right. So you have to leave some space when you clamp the cord, and you must use the plastic clamp and not a cord tie, right? So cut the cord about 5 centimeters from the baby's abdomen. If there is bleeding, put a second clamp, which is more proximal, right? Keep the stump clean and don't apply anything. So we should put the plastic cord clamp and not a tie like what you see, because the ties can get loose and it can bleed. So delayed cord clamping is you should cord the clamp after 1 minute after the baby is born, right? That will help more blood to come on to the baby. Why do we do this? Because it will give the baby more iron, more oxygen, which causing less anemia, better establishment of breastfeeding, better neurodevelopment, and lower respiratory distress. So before going to the postnatal ward, we must ensure that the baby has established breastfeeding, measurements, anthropometry are done, baby is clothed, and the vitamin K has been given. Right? And while the baby is in the labor room, we have to measure the vital signs every 30 minutes for 2 hours. And the doctor has to be informed if the respiratory rate is either less than 30, more than 60, heart rate should be between 100 to 200, and saturation, this should be changed, more than 95%. And we have to also make sure temperature is checked and the temperature is normal, right? So temperature control at birth, we have talked about this. There can be heat loss by evaporation. We prevent it by dry and cover. There can be heat loss via conduction. We prevent it by delivering onto the mother and heating our warmer. Convection, we close the windows, switch off fans, and radiation, we minimize overcrowding. What are the things we should not do? Do not deliver onto the delivery room bed. So we should always deliver onto the mother. Do not put babies born in good condition onto the warmer until the first breastfeed is completed. Don't weigh the baby until the first breastfeed is completed. Don't use cord ties, and don't wash the baby soon after birth. Right. So in summary, what we talked about in this part is how do we prepare for delivery? Why and how we deliver onto the abdomen and chest, how we dry the baby, assess the condition, clamp the cord. We talked about delayed cord clamping, skin to skin care. And if the baby is born in good condition, skin to skin and breastfeed. So we concentrated on a baby born in good condition, and if a baby born in poor condition, to resuscitate. And then but preparations or how we get ready to send the baby to the postnatal ward. Any questions from this part before I move to the next part? Anyone? Any questions with regard to the delivery and what happens? No? Okay. So then we are going to move on to handling the compromised baby, right? So this is a baby born in poor condition. Baby may be born through meconium stained LICA, or it can be a preterm delivery. So who is baby born in poor condition? Out of these two? Sharan? Sharan Kulandavadivel?
Yes, madam.
Oh, hi. Which baby is the bad looking one or the poor condition one out of these ones?
The one on the right
Yeah, why?
looks blue in color.
Yeah. What else? Compared to the other baby on the left? Yeah, you are right. It looks blue in color. What else? Does it look as if the baby is moving?
No, like the baby is not crying or.
Yeah, not crying, not moving. It's not a video, so you can't see, right? So those are some concerns, right? Okay, thank you. Good. Right, so this baby born in poor condition, we are going to go through it again. The color is blue or pale, tone is not good. So either floppy or moderate tone, breathing, either no breathing or gasping, and heart rate slow. Right, so in this condition, we need to start resuscitation. Right. Now, if a baby is born in poor condition, do you think it's a cardiac cause or a respiratory cause? Keshana? Keshana Tilakaratna.
Yes, madam.
Oh, hi, Keshana. Is it a cardiac cause or a respiratory cause?
It's initially we consider respiratory cause, madam, then the cardiac.
Yeah, usually for babies, we consider it a respiratory cause, right? That is why more main focus is on actually breathing.
Recording
Right.
stopped.
Okay, thank you.
Recording in progress.
So now what happens? How is gas exchanged before birth? So it is through the placenta, right? That is what you're seeing through this complicated looking picture. So basically through the placenta, gas exchange occurs and baby's carbon dioxide is removed and oxygen is given. And then therefore the right side of the heart. So the pulmonary arteries are not really working much because placenta is doing all the work. But after baby is born, baby has to take the first breath and the lung becomes the organ of gas exchange, right? But for the lung to work, the pressures have to go down. So if the baby doesn't breathe, the lungs are not going to open up. There will be no gas exchange. So then baby doesn't have any support from the placenta. Neither will the baby have any support from the lung. So this is where we need to help the baby by trying to help the baby with the expansion of the lung. Sorry. So if the baby cries, air enters the lung and gas exchange resumes. What are you seeing in this picture? Right, so what you can see is the lung is full of amniotic fluid at birth. Right, when the baby takes the first breath, air comes in and tries to push this fluid away. And with successful breathing, the fluid is pushed only to a thin rim. Right, and if the baby does not cry at birth, air does not come in, there's no gas exchange and the lung is collapsed. Right, so what happens is the alveoli are still full of amniotic fluid and the lung remains collapsed. Right, so when there is no gas exchange, there is hypoxia, and hypoxia will result in hypotonia and the tongue will fall back. This is why we make the first thing to do is neutral position, where we are going to straighten the airway so that the tongue does not fall back. So we need to open the airway for gas exchange in the lung. Right, so opening the airway, we have to keep the baby in the neutral position. Here you can see in the default position, because of the large occiput, the head is flexed forward. But by keeping our hands on either side, we can bring the baby to neutral position, that is facing the ceiling, parallel to the ceiling. If we hyperextend, again the airway gets kinked. If we don't extend enough and if it's flexed also, airway gets kinked. So the first maneuver first thing is temperature, so that is dry and cover. Then assessing color, tone, breathing, heart rate, and then the A in ABCD is neutral airway. Right, so here again you can see well how the baby is brought into neutral position and the face is parallel to the ceiling. So we have to reassess after neutral airway if there is no improvement. So again, after putting baby into neutral airway, we check CTPH. If there is no improvement, we need to support B, that is breathing. So we can do this either with bag and mask or a T-piece. So you have, I think most of you have now done the hands-on training. So you should know there are different sizes of bags, but we have to use the 500 ml bag, not the 250 ml and not the bigger bag either. We resuscitate using room air, so we don't use oxygen. Why not? Because 100% oxygen increases the work of breathing and it increases oxygen consumption, creates free radicals and reduces blood flow to the brain. You have also seen these masks, which I have told you there are 3 sizes. These are the silicone, cushion rimmed round face masks, right? So how do you choose the correct face mask for the baby? It should cover the nostrils and the mouth, but it should not go beyond the chin and it should not go over the eyes. So how do we hold the mask? We have to hold it in a 2-point hold. So that is with the letter C, right? So you use your thumb and second finger on the top surface of the mask and hold it as the letter C, and you use your third finger to join it with the mandible like the E hold. Right, so here you can see again how it is held. So C hold on the mask, push the mask down on the face and connect it to the mandible with your third finger, and using the wrist maintain the position. So once we connect the mask to the face correctly, then we are going to give very deep breaths lasting for 3 seconds each. 5 breaths, they are called inflation breaths. We count them 1, 2, 3. 2, 2, 3, 3, 2, 3, 4, 2, 3, and 5, 2, 3. Right? We are giving deep breaths because we know there is water inside the alveoli, and we need to dispel this water in order to get air in and to just compress that water into a thin rim. So we are going to give very powerful breaths. Right? By giving breaths, this is what we are going to achieve. So how do you know if the inflation breaths have expanded the lungs? One thing, you can see the chest expansion, and also you can see the heart rate is increasing. So if there is chest expansion, but the baby is not having spontaneous breathing and the heart rate is good, more than 60, then we only need to support the breathing. Right? So if the chest expansion is there, that means airway is patent and inflation is successful. So we don't have to repeat that. But since baby does not have spontaneous breathing, we have to give 15 ventilation breaths. Right? So we give this like each one takes 2 seconds. So squeeze 1, squeeze 2, squeeze 3, squeeze 4, squeeze 5, like that until squeeze 15. So squeeze 15 means we give 15 ventilation breaths per 30 seconds using the same maneuver. So once we give these 15 ventilation breaths, yes again. So, and keep continuing until the baby gets spontaneous respiration. So meanwhile, let's look at what happens to the heart rate. If the heart rate is less than 60, with visible chest expansion but no spontaneous breathing, again, chest expansion means your airway is patent and inflation successful, but no spontaneous breathing means we have to support breathing. So even if the heart rate is down, the first measure to take in if the heart rate is down is to continue to give 15 ventilation breaths. Right? So same maneuver. And then you reassess again. So after giving 15 ventilation breaths, if the heart rate is still down, you have to continue ventilation breaths, but we have to start chest compression as well. So chest compression will be given 3:1 in the midline, 1 centimeter below the intermammary line. And if that is unsuccessful in the next cycle, we start giving adrenaline via the umbilical venous catheter. Right? So this is how you do. You encircle the chest, you thumb over thumb, and you have to compress 1/3 of the AP diameter. So 3 chest compressions, 1 and 2 and 3, and while for 1 breath, squeeze 1. Right? So the UVC set will have a cord tie to tie the cord in case it bleeds. That is our fail safe. Then the scalpel blade. Then we have a flush syringe, then the NG tube or UVC, then the 1 in 1000 adrenaline in the 1 cc syringe, then normal saline to be flushed with the 2 cc syringe, then suture material and plasters. Right? So this is a picture telling you there are, so this is the cord tie. Before you do anything, you start with the cord tie. Right? And then you cut a clean slice, you identify the 2 arteries and the 1 vein. And then you have to lift it up with your artery forceps and insert your UVC. And in a case of emergency for resuscitation, you put this H plaster. Right? So if the heart rate is less than 60, no chest expansion, no breathing. So if there's no chest expansion, no heart rate, no breathing, this means your inflation breaths have been unsuccessful. So we have to recheck the airway and look for neck flexion and correct whatever has gone wrong and repeat the inflation breaths. Right? So commonly when we get tired, the neck can get flexed. So make sure the neck is in the neutral position and the face is parallel. So again, to recapitulate, so we start with T, A, B, C, D. T for temperature, dry and cover, airway, breathing, circulation, and drugs. Okay, so let's look at few situations. So the color is pale, tone is moderate, no breathing, heart rate is rising, chest expansion plus. What action would you take after you have given the first round of inflation breaths? Pabasari.
Madam, I will continue with the ventilation breaths, 15 ventilation.
Okay, good. Right, different situation. Hiruni. So again, color pale, tone moderate, no breathing, heart rate is slow, not increasing. What will you do now? And chest expansion is there. Hiruni, Udara.
Madam, give ventilation breaths since ventilation breaths have not been given yet.
Yeah, good.
15 breaths.
Right,
And then
good.
reassess.
Right, good. Now here, again, situation 3, Chaturi. Here there's no breathing, heart rate is slow, and no chest expansion. What will you do? Chaturi?
We want to see the airway and in neutral position. Then after first round of inflation, we want to give 15 ventilation breaths.
So what would you do first? Tell me in order now. What do you want to do? Do you want to give ventilation breaths? So you said something about the airway.
We want to give ventilation.
But here,
breaths,
what has happened? Has the first set of inflation breaths worked? What does this tell you? Chest expansion is not there. Heart rate is not increasing. No breathing. Has the inflation breaths worked? The first set.
Inflation.
So has it worked or not, Chaturi? Take one step at a time. Has the first set of inflation breaths worked?
Chest expansion is there, not there. So
Yeah.
inflation breath is not work.
Not
So,
right. Yeah. But then what do you do now? Now the previous situations, inflation breaths had worked, but here it has not worked. So what will you do differently?
Again, I want to check the technique what we inflation breaths are giving. Keep the head neutral position and again give one round of inflation breath.
And you have to assess, right? So here you have to repeat inflation breaths after correcting your technique, right? Good. Right, so be careful. If the inflation breaths have not worked, you will have to adjust your technique and repeat the inflation breaths. But if they have worked, either you have got chest expansion or heart rate has increased, then no need to repeat inflation breaths. You move to ventilation breaths, right? Okay. So oxygen saturation targets, right? So you can see at 1 minute it's 60 to 70, and even at 10 minutes it's only about 90. So this is why we are not in a hurry to put on the oxygen saturation monitor. So even if you put it on, you must be aware about what is the saturation for that period of time. So let's look at what happens for the small baby, less than 34 weeks, less than 1,500 grams, right? So the small baby, we have to take the baby into a plastic bag and keep under the warmer. So we cannot dry because we can cause damage to the skin. So therefore we need to use a plastic bag, right? So this is how the plastic, it's a food grade plastic bag. You have to unroll it, and from the foot end, you roll it up and keep the baby in it, and you have to keep it under the warmer so that the air circulated inside that bag is keeping the baby warm. So this is what is called a neopuff machine or the T-piece machine, which is also used, right? Which can also use positive air pressure. Here it's slightly different. You can set the pressure and you just work the finger up and down to give it. So this is the transport incubator. So these are the things we have to get ready for. If we know it is a preterm delivery, we have to get ready with our plastic bag, the neopuff machine, as well as transport incubator. We have to prepare a bed in the neonatal unit as well. Right, so that's about the small baby, right? So small baby, instead of dry and cover, we use a plastic bag. What happens if there is meconium stained lico? So same steps in resuscitation until inflation breath. But if there is no chest expansion, then we use direct vision to look for the meconium. So we use the laryngoscope to visualize the larynx. And if there is meconium, we have to suck out with 12 to 14 French gauge suction tube and repeat the inflation breaths. If there is no response, then we have to intubate and ventilate. So this is what the straight blade laryngoscope looks like. There are different sizes which are used according to the baby, but important thing for you to remember is that it's a straight blade laryngoscope, not a curved blade like used for adults. Then there are different sizes of suction tubes, but what we need is this size 12 and size 14. We need big size suction tubes because meconium is particulate. Right, so the wide bore suction tube that we need is 12 to 14 French gauge, that is green color and white color. So the maximum suction pressure that we apply is 100 millimeters mercury, and it should be applied only during withdrawal. So you have to actually set this machine before you wash your hands when you attend the delivery. Right, so if we summarize the procedure of what we do, right, with resuscitation, first is dry and cover. Without the preparation bit, of course. So you have to prepare. Then when the baby comes, dry and cover, assess the CTBH, neutral airway, reassess CTBH, give 5 inflation breaths, right? If baby is crying, we stop resuscitation. If there is no chest expansion, no increase in heart rate, we have to reassess airway and repeat your inflation breaths. If there is chest expansion, but no spontaneous breathing or the heart rate is low, you have to start 15 ventilation breaths, right? So if the heart rate is more than 60, you have to continue ventilation breaths until the baby develops spontaneous breathing. If the heart rate is less than 60, the next step would be to give chest compression 3:1. Still the heart rate is less than 60, then we have to insert the umbilical venous catheter and give adrenaline. Right, so that is the process of resuscitation. Right, does anyone have any questions on that before I move to the physiological basis? Okay, so if you don't have questions, I'm going to move on. So we talked about this. What is the main cause of collapse in adults? It's cardiac, and in children, it's respiratory, right? So this is what we have based our resuscitation protocol on, that we are basically trying to resuscitate a baby where the breathing is the problem. So what important factors might affect resuscitation? That they are small, wet, and the lungs are full of fluid. So at birth, babies are prone to hypothermia. They have unexpanded lungs. They take 10 minutes for oxygen saturation to be 90%. They have the capacity to do gasping breathing, as well as they have high glycogen stores in the heart. So what actually makes them breathe for the first time? No one really knows, but it is thought that it's a physical stimulation, clamping of the cord, and temperature change. So what happens with the first breaths? So the first breaths push the fluid from the airway and the alveoli and help to establish the resting lung volume. So long time ago, someone has done these x-rays, which you can see, where the lung is full of fluid, and within seconds, the fluid is being cleared and the lung is open. So the response to hypoxia has been found out actually by animal experiments using a fetal lamb, taking the fetal lamb out of the uterus, right? And dunking the lamb's head in water and in disabling him to breathe, or her, right? And they have looked at breathing changes, level of consciousness, blood pressure, heart rate, PO2 and PCO2. Right, so here now what has happened is the baby has been breathing, right? And the head has been submerged in the water, so there is no breathing. Oxygen is going down. But after a while, even without intervention, you see this gasping breaths. So they are deep and slow breaths are coming, right? but still the head is still inside the water. So there is no way that this lamb can get oxygen. It goes on for a while and then it stops. So that is the terminal apnea. Gap between the regular breathing from the respiratory center and the gasping breathing from the spinal center is called primary apnea. You don't need to differentiate between these two. So initially we get breathing from the respiratory center in the medulla, which is more high functioning, requires more oxygen. But then if that doesn't have oxygen, it shuts off, and our spinal center, the inhibition wears off and the spinal center starts working. That gives the gasping respiration. But after a while, if there's no oxygen, that will also die off, and we have then no capacity to breathe on our own. Right? So breaths are originating from our respiratory center, right? That is what is happening with us. It is usually, so when the breaths are originating from the respiratory center, it usually suppresses the spinal center, right? But if the respiratory center is not working, the spinal center becomes active and gasping respiration occurs, right? So what happens? If there is no breathing, no gas exchange, carbon dioxide levels will go up. You can see heart rate increases slightly, right? But after a while, when there is no oxygen, it falls and it is at a lower level. But it takes 30 minutes to stop because we said the heart has a high glycogen store. Meanwhile, when there is less oxygen, we switch from aerobic to anaerobic metabolism and lactic acid starts increasing, and that results in excess acid. Blood pressure remains relatively stable and is kind of the last thing to go down. That's why it's not very useful, to monitor blood pressure. And why does blood pressure stay like this? Right? So we talked about redistribution of blood flow when we talked about HI, right? So it shuts down circulation to the non-essential areas and gives blood preferentially to the vital organs, heart, brain, and adrenals. Right? So the baby can be born in where any of these arrows are. It can be born here between the regular breaths and gasping. It can be born during the gasping breaths, or it can be born after the gasping breaths. So let's see what happens. If we take the first instance, right, so the baby is born, and if we do nothing, what will happen? So we don't know whether the gasping breaths have happened or not. All we know is there's no breathing yet. So if we do nothing, after a while, the baby will start gasping, right? So we have taken the baby's head out of the water. Here, the fetal lamb's head out of the water. And he can now breathe if he wants to. So he has started, the gasping respiration has started. And that will lead to correction of the problems, increase oxygen, reduce carbon dioxide, heart rate will go up, and baby will be all right. So no need to intervene if the airway is patent. So here the change we have done is we have taken the lamb's head out of the water. So the airway is patent, right? So just when the airway is patent, baby can be okay. So that is why in our resuscitation, the first thing to do is keep the airway patent. The baby is born here. Right? The second situation. Here again, with the gasping respiration, the baby is born. So with the gasping respiration, he's born while gasping. So he continues to gasp, get the oxygen in, and when there is enough oxygen, the respiratory center will start working and the anomalies will be corrected. So longer period of gasping, but again, no need to intervene if the airway is patent. So what happens if the baby is born here? We take the fetal lamb out here, take his head out of the water. Now here you can see gasping is there, but gasping period has also finished. So if we do nothing, there is no capacity for this lamb to breathe because now his gasping center has stopped, respiratory center has stopped. And if we do nothing, the baby will die. Right? So in practice, we assume all babies are born in terminal apnea. So we don't wait to see whether gasping will come or not. We don't wait to differentiate, try to differentiate, is this primary apnea or terminal apnea? We assume every baby is born in terminal apnea and we start resuscitation. Because if we don't give the breaths then the baby will die. So if we give the breaths to this baby, and see the baby will inflate the lungs and start ventilation. Right here you can see this baby, when we have started giving the breaths, heart rate has increased and gas exchange has resumed. So if the baby cannot breathe, we have to inflate the lungs. Now here again you can see we have supported the baby at terminal apnea. We have inflated the lungs and we have given the ventilation breaths as well. And baby has gone back to normal and resumed normal breathing. Here what is different is we have supported the baby with the breaths, but although we have started ventilation, heart rate is still down. Right, so this baby would have been more hypoxic than the previous one. So here we have to give ventilation breaths. Still, if there is no response, we have to start chest compressions, after which if there's an increase there, we have seen an increase in the heart rate. So it is based on this physiology that the resuscitation protocol has been made, because we know if the airways has to be open for everything else to work. So that is, we have to do it in that particular order. So even in a baby who doesn't breathe, who has no heart rate, you never start with trying to give in chest compressions, because all you will do is push deoxygenated blood from one place to the other. So before you give chest compression and push the blood into the coronary arteries, you have to make sure blood is oxygenated. And that is why you have to make sure your inflation breaths work. So when a baby is born, we don't know where the baby is, whether it's terminal or primary apnea, right? But we assume it's terminal apnea all the time. And we start resuscitation. Any questions?
Recording stopped.
Does anyone have any questions either on the physiology or the resuscitation per se? Most of y'all, I think, have done the resuscitation. I think only one group is left next week to do. Any questions? Anything you want me to clarify?
Excuse me, madam.
Yes.
Madam, how are we giving the inflation breath and ventilation breath? How it is different in the procedure?
Have you done the neonatology appointment?
No, madam.
Then you will learn when you come. Inflation breaths, you have to squeeze the bag all the way through, and ventilation breaths just a little bit to simulate the baby's breathing. When you do it, you can understand it better. Any other questions? If it is the procedure per se, for those who haven't done it, you will get a chance to do hands-on, right? If you want to know how to do it, the best thing is we can do it when you come to do it. For those who have already done it, but even the ones who haven't done it, if you don't understand anything about how it makes sense and what is the basis behind it, ask. Any questions? If there aren't any questions, we can end the session. Ask quickly. You can send in the chat also, but the practical procedure, if you want to know how to do and if you haven't done, you can learn when you come next week for the guys who haven't done. Others, if you have already done, any other questions regarding the theory component, the physiology, any of the things I told today, you already must have known. Just wanted to add the physiology part actually was the call. Anything? No? Okay, so if there aren't any questions, we can end the session. So I hope everyone is clear about how to decide which action to take at which time. How you decide whether you are going to give ventilation breaths or chest compression, or do you need to repeat the inflation breaths? When do you need to insert UVC and give adrenaline? I hope you are clear about the answers to those questions. Okay, so no questions. Okay, so we can end it then.
Thank you, madam.
Okay then.
Thank you, madam.
Okay, thank you for joining.
Thank you, madam.
Okay.